Okay. Hello, everyone. My name is Emily Bielzinski, and I am part of the Smartin Student Research Team, who's helped organize this conference. And I have helped organize this panel today with my colleague, Elizabeth James, who is here somewhere, who will be popping in and out of the chat. We're so excited to have everyone. We're so excited to get started with this. The sessions yesterday were amazing. I hope that for those of you who attended, it was informative and it was very interactive, and that today will be just as fun. So before we get started, I would like to ask you guys a couple questions. I would like to introduce a couple questions. What do you guys think is the most effective intervention method? And how can universities stop students from having a mental health crisis? Now, of course, these are completely rhetorical questions that don't have black and white answers. And if you did have the answer to this, please keep it to yourself or you would spoil the rest of our session. But I wanted to start with these questions because these are some of the hundreds of questions that have been sent in to the Spartan Network by hundreds of students across the UK that they think are key questions researchers should focus on when researching mental health. And I think that they give insight into the importance for us students of having evidence-based intervention methods and attest to the range of interventions offered to students, which at times can be overwhelming or even confusing. Now, of course, mental health aversive experiences are a tremendously intimate yet universal facet of being human. I'm sure everyone here today, including myself, has experienced some degree of struggle with mental health. But for higher education students, I feel like mental health difficulties are uniquely poised to snowball and have long-lasting consequences. And this is for lots of different reasons that we all know of, such as loneliness, academic stress, which was discussed yesterday, and psychological resilience, and the fact that half of us still have underdeveloped frontal lobes. Now, indeed, higher education is characterized by a time of exhilarating independence, which can be a double-edged sword. I know that my personal experience as an international student who had never been to London before, the pressure I felt to make friends and establish my support network was huge. And this brought feelings of exclusion or guilt when I thought I wasn't being social enough. Of course, everyone will experience higher education differently, as it is also described through your personal characteristics, such as what you look like, what you sound like, how you present yourself. So it follows each student will have different intervention needs. So how can universities balance the uniqueness of what works for each person without crossing into a concoction of shallow and ineffective intervention methods? And this is exactly why we've organized this panel today, to start, or rather contribute to, an informed conversation about intervention methods, asking important and maybe even uncomfortable questions. So we hope that after this session, we have given you food for thought and opened the way for students to be better informed and giving you the tools to become involved in your university's intervention implementation.
I'm going to ask each of my panel members to say a few words by way of introduction. So first of all, I'm going to turn to Leigh Spanner, who is the lead for Student Minds on the University Mental Health Charter and the Student Union Support Programme there. And it would be really interesting to understand, Leigh, a little bit about what you think about who is responsible for providing mental health interventions at universities.
Hi everyone, hope you're all well, and thanks for having me and thanks for the introduction, Nancy. So who's responsible for mental health interventions at university? I guess the first thing to say is that we know that a wide range of environmental factors impact our mental health and well-being, as Emily was saying as well, that's very different for different people. So that means that basically every aspect of our university life can have an impact on our mental health and well-being, whether that's your learning and teaching environment, whether it's the day-to-day interactions you have with staff and students, the accommodation environment you're in, and just like kind of the buildings around us and how we navigate those. So I guess the short answer is everybody has a kind of responsibility there. I guess in 2019, Student Minds undertook a huge project with thousands of staff and students across the UK, and together we created the University Mental Health Charter. And within that charter, it sets out kind of how the whole university can start to have a positive impact on our mental health and well-being, and it really looks at all different areas of the university as well. So it talks about having really safe, effective, accessible and well-resourced support services. So there's mental health support services, and they are absolutely essential. But then also having a range of proactive interventions from across the university to promote mental health and well-being, but also to prevent mental illness. That universities need to also create a kind of mentally healthy culture and environment for staff and students to live in, and studying and working, and also giving staff and students the tools they need to manage their own well-being as well, and that's all important. But when I say that the whole university has a responsibility, that doesn't mean that universities just need to take an absolute scattergun approach, as Nancy was saying. A whole university approach set out in the Charter means taking a real strategic approach, so informed by evidence, a real understanding of each individual university community and what their needs are, and the best ways to meet those. And then also to keep evaluating, to keep learning about what works and what isn't working, and keeping improving that approach as well, and that's really important too. So in the past year, since the publication of the Charter, we've been piloting the University Mental Health Charter Award, and hopefully that will open for applications in early 2021. And the whole point of that is to encourage universities to really start to have this kind of self-reflective process where they start to evaluate all the different things they're doing around mental health and well-being, and together we can recognise where there's some really good work there and what is working, and then share that learning with the rest of the sector. So we're really excited to kind of hopefully through the awards start to see more of that practice within universities themselves. So I guess everyone, but in a certain way, in a strategic way, in a way in which we're evaluating what we're doing at all times and really understanding what works.
Brilliantly, thank you so much. Certainly the evidence supports the idea that individual interventions work, but where we get the biggest impact is where it's organised and linked in together. So that's fantastic to hear. That's what you're finding as well. I was also pleased to hear that you talked about informed by evidence rather than evidence-based, and also understand your people and your context. And I think that's really important. I would underline that. Thank you very much, Leigh. Please remember to post your comments and questions if you've got a thought about what Leigh has said today on the chat window, but also using the conference hashtag SmartinConf on social media. Bethan, really great to have you here. Bethan Davies, you're a research fellow at the NIHR funded MindTech. It'd be great to understand what you think about the technology, digital technology's role in helping fill this need, and what universities are doing, but how good they are and how we know, I suppose.
Yes, thanks for the introduction, Nancy, and for having me. So as you said, I work as a researcher within the MindTech research group at University of Nottingham that focuses on the development, adoption and evaluation of digital technologies for mental health care and implementing them if they prove to be effective. So digital mental health has been quite a hot topic now in research and practice for several years, but sort of the current pandemic has really brought this to the forefront and really accelerated the process. So we've all had that week where we sort of had to switch to online working and all that. So my work involves considering how digital technologies such as online interventions programs, apps, online support groups and things like virtual reality can be used to aid people's management and treatment of mental health issues. And I particularly focus on children and young people, although I've yet fully blend sort of evaluating online interventions in student mental health. So as part of this, I'm very aware that universities have been involved now in providing low-level mental health and wellbeing support through self-help digital interventions to their student groups. So Silver Cloud and what was called Big White Wall is now Together All are two programs that some people might have heard of. And often university counselling services and the wellbeing services within universities often have a web page which is about sort of self-help resources, including signposting to smartphone apps. But in providing these to students, we have to think about how effective they are, where that evidence comes from, and whether students are actually quite interested in these sorts of things. Because so for example, there's loads of apps out there which say that they're for your mental health, but it's difficult to pick out what's good and what's not so good. There's been a few reviews published for various online interventions and apps that have been tested out in students. But likewise, many students might be being signposted to apps and other online resources that might not necessarily have evidence to support their effectiveness. and furthermore, evaluating like digital tech might be required through like a randomized controlled trial. That takes a lot of time and resource to do, and by the time you've done that, it might be that the digital tech doesn't exist anymore or is in some sort of new form. And it also might be that digital interventions might not have been tested out on students who are more at risk of experiencing poorer mental health. So, for example, thinking about the makeup of the student population has changed quite dramatically in the past 20, 25 years. There's been increased access to education from what they would often call sort of non-traditional backgrounds, and this group might face different risk factors for experiencing poorer mental health. And then finally, the digital divide still very much exists. There's an assumption that everyone has sort of equal access to technology. We've all got a smartphone or whatever, but you know, it might be thinking about the current pandemic that when that the app came out, the tracking app, there were certain numbers of users who had an iPhone. They said it doesn't work on my phone anymore because it's old technology or it's issues with the operating system. So it's sort of just because most of us have some sort of digital technology doesn't mean we all have the same equal access. I'll finish there.
Thanks, Bethan. This is a brilliant question. Actually, it's one of the ones that the Lord's Life After COVID committee is considering at the moment, thinking about, we've had the pandemic with this rapid acceleration of this shift to digital. There's some real advantages. We've got like 154 people able to join this conference today. We're able to talk about it, but then also how do we make sure that everyone has access to it? And it's no point having that app downloaded on your phone or whatever if you're still sat on the couch, not doing your C to 5K, even though that works. So there's some really great research happening around the digital space. Thank you. Jason, we've got a question for you here. So Jason Arday is an Associate Professor of Sociology at Durham, but also among other places. Jason, what are the race issues around this, and how do we develop a non-racist student mental health services?
Thank you so much, Davies, and thank you, Leigh and Bethan. It's a privilege to be part of this panel. I guess the first thing is that there has been, I guess, an absence or recognition that Black and ethnic minority students face really, in many respects, very unique and complex needs, and a lot of them are racialized, and they kind of couched within, you know, in many cases, navigating an institutionally racist society. And I guess for many of those students and staff, very often, in kind of encountering and navigating, traversing this kind of racialized terrain, there aren't actually any psychological interventions to help them manage the trauma of going through these experiences. And very often when they find themselves in racialized spaces or spaces that are marginalized or victimized on the basis of race, this can be triggering. So for me, I think what we do need to move towards as a sector, and a lot of my work has kind of worked towards this, having worked with clinicians as well, is really to move towards culturally appropriate psychological interventions that are really kind of focused around recognizing the kind of nuanced needs of Black and ethnic minority students and staff, recognizing really the impact of racism upon their psychological and mental state. I think what also becomes important is training. So the training that mental health care professionals engage with, and really moving beyond a very kind of Western Eurocentricized kind of version of, I guess, psychological training. And again, really kind of thinking about what are the kind of pastoral interventions that we should have in place in terms of, you know, negotiating racism, or kind of, I guess, yeah, traversing racism in terms of from a psychological point of view, because there are kind of these lacerations that kind of is that whole, for example, we think about the racial microaggression, it's death by 1,000 cuts, so it's cumulative, and that kind of cumulative wearing on wear and tear on mental health does create kind of a racial battle fatigue that can create, you know, really long lasting effects and can really compromise well-being in a way that, one, kind of compromises, I guess the obvious thing would be educational attainment, but two, physical and mental well-being. And I guess that becomes kind of a really salient issue when we think about maybe the absence of services or the lack of diversity in terms of healthcare professionals that work within our universities.
Jason, thank you so much. The breadth of things that you were covering in that 2 minutes was huge. So everything from fairness, the managing the experiences of racism and that cumulative sort of fatigue that comes with it, the frustration and anger, no doubt, and the culturally appropriate interventions, and also the training for staff. There's a whole breadth of things in there and how we understand that in this context for particular groups of students. Thank you very much. My last panellist, I'm really excited. I've been working with Dr. Joanna Worlsey from the University of Liverpool for a while now, and she is going to speak to us a little bit about our learning from what interventions work from the review of evidence that she did with the centre.
Thanks for the introduction, Nancy, and thanks for having me. So just going to give you some headline findings, really. So we reviewed evidence on interventions to improve general mental health and wellbeing, and there's actually more known in this area than we thought, or that was the feedback that we had from our partners. So we identified a range of interventions for student mental health and wellbeing, including mindfulness, psychological interventions, psychoeducation interventions, recreation programs, relaxation interventions, and setting-based interventions. And we did locate a large body of evidence on specific interventions such as, say, mindfulness and CBT. And the evidence suggests that these interventions can effectively reduce common mental health difficulties in students, as when compared to a passive control, both mindfulness and CBT appear to be effective. And we also found evidence that suggests the effects of CBT-related interventions are sustained over time. Now, we know that CBT works with other populations as well. So moving beyond CBT, there are other psychological interventions which have been shown to be effective in other populations. So that also opens up what we can do as well. Recreation programs were also found to be effective, and actually in one higher quality review, although both mindfulness and CBT were found to be effective, other interventions, so art, exercise and peer support, were found to be more effective. Psychoeducation interventions were not as effective as other interventions such as mindfulness, CBT, relaxation and meditation, and the effects of psychoeducation do not appear to sustain over time. So overall then, our review establishes effective ways to improve student mental health and wellbeing. It's a first step to develop the evidence base. It does reveal gaps. So for example, although there were a large number of reviews on, say, mindfulness and CBT, review level evidence was limited in relation to other intervention types. So this means that it's not currently possible to weigh up what works best, where and for who.
Thanks, Joanne. Sorry, you caught me unawares at the end there. So this is a massive first step, I think, in understanding what we already know. And when I say we already know, this was looking at what we know globally in countries similar enough to the UK for it to be useful. And it showed actually we knew more than we think. But there are evidence gaps, and there's some things that look like they could be worth looking at in more detail. I guess there's also some things that we do already that aren't, that we do extensively already that haven't been researched as well. Is that right?
Yes, so there were a number of gaps in the evidence base, and there are some things that maybe student services do and they find are effective, but they're just not appearing in the evidence base as yet. But hopefully if we were to do the review again in, say, 5 years' time, there'll be more evidence.
Brilliant, and we've got some research call alongside this conference to help us fill some of those gaps, which is exciting. Thank you so much. I have got an amazing load of questions coming up from so many of you. So I'm having a go at trying to work out who in our panel would be best placed to answer it. So I have a couple of questions for Jason straight off. So Jason, is there any training that you would recommend, and how can we become an anti-racist mental health researcher? Big questions for you to kick off.
Hi, Nancy. No worries, and thank you so much for the question. The training that for me I would really recommend is really one of two things. I think one is more of a it's not as penetrative, but it could be useful. So unconscious bias training. I think another one would be another form of training which I do think would be more penetrative is around kind of white allyship training and recognizing how any form of privilege intersectionally can compromise views and understandings around kind of psychological intervention. So a lot of the research that I've done, a lot of staff and students who've often utilised university counselling or pastoral services have often spoken about a gaslighting or neutralising of kind of racialised experiences. So it's kind of always leans towards being hypersensitive, or are there other stress factors, and really kind of neutralising race. So I guess the kind of practice that I would advise, or the kind of training I would advise, is really kind of seeking to look at how other countries have used psychological interventions to manage and understand race. So there are two particular countries that I think have done this really well. I think the US has done this really well in terms of providing specifically psychological interventions that help people not navigate race, but understand how racism occurs, why it's happened, and what these potential triggers are, and provides them with mechanisms to be able to deal with this. Not that you ever learn to deal with racism, but it's a kind of understanding of why this happens and equipping yourself with mechanisms or tools to navigate this. And then the other would be South Africa, and I guess there's that kind of apartheid backdrop to all of that, and kind of having cultural interventions and kind of psychological interventions around how to kind of deal with the impact of whiteness in terms of its, I guess, historical legacy and the weight of that in terms of its institutionally racist legacy. So those would be the things that I would advise in the short term.
Thanks, Jason. I've got loads of questions coming in. Please keep posting them in there. I'm going to take advantage of my chair of the panel question to say, how much can we use what we already know from the evidence base to influence what organisations like universities and other parts of the universities invest in? And I was going to go to Bethan and then Joanna on that one.
Can you just repeat that for me, Nancy? Sorry, my sound cut out then.
No worries. I'm not trying to understand how much we can use the evidence that what we already know to influence what universities and other organisations invest in to improve student mental health and wellbeing.
Yeah, I guess one thing to think about is if universities want to uptake an intervention, what sort of outcomes are they looking at? What outcomes are important to sort of the university management, but also then think about what's important to students? Because it might be that they differ a lot. So it might be that universities are thinking about cost effectiveness. So how can we reach the most with spending, like, not the minimal amount, but a reasonable amount? Whereas students might be, right, how will doing that, what change do I expect to see? What do I expect to happen to myself as a result of doing an intervention? You know, is my mental health going to get better? Is it going to help me get A grades? Is it, you know, whatever? Is it going to help me socialize more? So I guess it's thinking about, we've got sort of different stakeholders and what sort of evidence they want, and the evidence that might sway them into sort of supporting an intervention, if that makes sense. I hope that's I don't know if that's answered the question, sorry.
Yes, that's really interesting in terms of what's cost effective. And I think it's really interesting. We're getting much more aware of what makes a cost effective intervention, what we're trying to achieve in the current pandemic. So you can see that the goal is to have affordable, effective, inclusive interventions that work over time, and you can see that that are used in the right places at the right time. And you can see that with the pandemic, for example, where we're repurposing common drugs that are effective in this context. And I think that's probably true of technologies we can repurpose. Commonly used accessible technology.
Yeah, it is. I've seen like a few online interventions that have then adapted for sort of COVID and added extra additional like COVID related anxiety things or things like that. So that's sort of scaling up that, as it were. Yeah.
So we can reach people effectively in a broad way. And I think I was going to ask Joanna the same question. So how much can we be using this, or should we be using this, to influence what we invest in as organisations?
So I think if you look at the evidence, both mindfulness and CBT were shown to be effective when compared to passive controls. So people are either adopting mindfulness or CBT approaches, but maybe without giving much thought to the student context. And I think moving forward, I think we need to look beyond CBT when assessing what works. And I think it's been particularly important to consider the upstream determinants of student mental health and wellbeing. So in this context, an example would be students' living environment, so quality of their accommodation, social relationships, etc.
Thank you very much. And actually, I was just wondering, Leigh, was there anything that came out from your work with University Mental Health Charter and the Student Union programme in that way, or what they should be doing or could be doing?
Yeah, absolutely. I really like the fact that the reviews highlighted that kind of settings-based approach as being, there's some evidence there that it's effective, because we're still seeing that in universities and even some student unions a kind of hesitancy to see, if you're not in a traditional wellbeing or pastoral role, that's got nothing to do with you, or your academic experience and your wellbeing experience should be completely distinct. So I think as soon as we can get rid of that narrative, the better. And it's about how do we communicate that, and so things like the charter that can kind of give communicate that to universities and give them a mechanism in which to engage with some of that evidence. Seems, we're already seeing universities starting to create kind of working groups, and people in our SU programme as well are doing the same, where they're starting to do that mapping process of saying, well, what are we actually doing across here, and where can we make those links and join up, and where are the things that are missing from what the charter's saying already. So we're already seeing that thought process happening, which is great. But I guess same with other colleagues as well, is it's about how do we use this evidence and frame it in the right way. So mindfulness and CBT obviously stuck out here as being far the kind of biggest impact that you could have for mental health and well-being, but then we know that that's not going to work for everybody, and just throwing all your investment into that one intervention isn't going to work either. And there could be so much that we're doing that either is working really well or actually damaging, and we need to start thinking about that in context as well. So understanding that there are gaps and that universities can really help us to start filling those gaps as well is really important, through just starting to think reflectively about what they're doing and starting to evaluate some of the stuff they're doing. Because we're seeing in the award as well, universities, this is the first time a lot of the time they love saying, we've got all these things, look at all the wonderful things we're doing for mental health and well-being, but as soon as you ask, well, how do you know it's working? A lot of them have stopped at that point and haven't actually embedded any kind of evaluation, whether massively rigorous or just some kind of simple evaluation in there. So I think there's still a lot of we can do, but that conversation is starting, which is great to see as well.
Thank you very much, Leigh. It's worth saying that just because the review of reviews found strong evidence around some of the psychological interventions, the evidence base needs to be more rigorous in that space. And actually we also found, I think Joanne's nodding here, which is great, which means I've on the right track, which means also there were other things that look like they could be more effective than those interventions. That it's also worth saying that some things that we are easier to evaluate than others, and therefore, or there's more incentives to do it. And this is why I was referencing some of the things that we do a lot, but we don't actually, we haven't looked yet in a rigorous way. We haven't taken it as seriously as perhaps we could do. This leads me on to a great question here I've got from Amanda, and actually I think she's not the only one who's asked this question. Amanda Green, how do you define success measures when evaluating interventions, and what is success for that? And actually also alongside that, I think is the long-term, how do we understand that the long-term impact of interventions? And I think might be Joanne is a good place to start with this one, or Bethan. Joanne.
So I'm actually currently involved in an evaluation of a brief therapy. And it's actually a systems approach, so we're linking up with our local NHS service. So in terms of the evaluation of that particular intervention, we are looking at pre and post measures, so psychological distress and self-harm. And then we're going to compare the pre and post And we're also going to look at, so we're going to collect a measure before every session as well, just to track change in psychological distress.
Thank you very much. Bethan, or Leigh, is there anything else you wanted to add on that, or Jason?
Yeah, again, sorry. Yeah, it sort of relates to what I said previously. Different stakeholders might just have different sort of what they mean by success. Someone might think, the university might think, oh, does that mean fewer GP visits, fewer prescriptions for antidepressants from the local, the student health service, things like that. And it comes a lot if you're doing like a portable evaluation trial of a digital intervention. This is where sort of qualitative research is really valuable. Quantitative research really good at telling us numbers A to B. Oh, there's a decline. That's good. You know, some people want a lot of the stakeholders want those numbers to say, right, there's been a decline in depressive symptoms, for example. But then the qualitative aspects tell us more the whys. Why did it decline? You know, what was it about the intervention that helped? But also looking at other things, other important outcomes which weren't quantitatively measured. So I'm just thinking of a trial I've been involved with, which was about Tourette syndrome, and the measure for that was about number of tics they had. But when we did the qualitative, they were talking about it's made me feel more confident, more able to go out, things like that. Things which are more just as valuable to the people that take part. So it's more than just numbers, basically.
That was very elegantly done. The question I had was a wonderfully geeky question, which is the same, which is what is the balance of quantitative outcome measures as to qualitative, and how much evidence is there from a qualitative perspective to understand the effectiveness of interventions? And this is brilliantly geeky, and actually the qualitative evidence that you've described helps us understand what's important, what measures we should be using, how things are working. Joanne, do we have a sense of what the balance is? Because I know we've looked at both quant and qual in the evidence base.
So with regard to the review of reviews, the reviews that we included were quantitative, but I do largely agree with Bethan's point in terms of the qualitative evaluation. So just to clarify the evaluation I spoke about earlier, we are also including a qualitative element. So we are going to talk to the students who are engaging with the therapy, and we're also going to talk to the therapists as well. So it is about understanding whether the evaluation works from a number of different stakeholders. So in addition to the quantitative evidence, so the pre and post, etc., it is very important to collect that qualitative data, just so you can understand the why. So why is this working, or why is it not working?
Yeah, so getting a sense of the why and the how and what matters can be useful with that qualitative. And there's certainly ways, we've used qualitative evidence in synthesis in all of the centre's work that helps us, and there are more robust ways of doing it, it can be more reliable. I had a question here, it's quite specific, which is from Dominique Thompson, which is about, are there interventions that are effective for emotional instability and self-harm, which we find is increasingly common an issue for students? No one. Joanna or Bethan or Leigh, or Jason, do you want to? Do you have an answer for that one? Getting no responses, so maybe we have an evidence gap. Joanne, go for it.
I can have a go. Could you just repeat the question for me? Sorry, Nancy.
Slow down, I'm trying to read too many things. So Dominique Thompson has asked, I would like to know about interventions that work for emotional instability and self-harm, which is an increasingly common an issue for students.
Mm-hmm. So the evaluation that I'm involved in at the moment, that is an intervention for self-harm, and it involves students, so once they present, they receive therapy within 72 hours, and it's once a week with a therapist. And although it is hoping to reduce self-harm, it talks about feelings and maybe reasons why people are self-harming. So in terms of the question, I can't tell you whether it's effective or not, because we're currently in the middle of the intervention, but hopefully over the next year I'll be able to feed back if anyone's interested in relation to those findings.
Thanks, Joanne. And also I think there's some great comments in the chat about people who've got experience of this as well. And we know from the review that quite a lot of psychological interventions that have been effective with other populations also work for students. So the suggestion is that things would work that come across. I've got another quite specific question about the lack of diversity in student mental health support networks, which can differ quite a lot from university to university. That it is clear that there is differences in diversity. How can we make these spaces feel safe for people of ethnic minorities to work and to come and ask for help? I'm going to go to Jason for that question. Yes, you've got your hand up. Thank you.
No worries. Thank you so much for the question. I think in terms of making these spaces safer, I do think, as I've mentioned, there needs to be a recognition of the impact of racism upon people's everyday lives and their lived experiences. I think it's really important for universities to really invest in culturally specific mental health interventions around these kind of issues. I think probably another prevalent part of this is really kind of understanding how these spaces can be violent, how they can be systemically violent, and how they can cause kind of psychological triggers for people encountering racism. So again, I think diversification amongst mental health care practitioners is really, really important. There is an absence, even though we know that there is a significant number of Black and ethnic minority mental health practitioners within the industry or the service as a service within the NHS and beyond. We don't see that in terms of universities. And when we think about the kind of person specifications that are used to bring in practitioners, very often these considerations are not factored in. So, you know, the diversity or the composition of healthcare professional teams, the cultural understanding and knowledge of teams across the intersection. So I do think certain intersections are prioritized over others. And while I think they're all, and my argument would be they're all important. So you do need to make sure that kind of broad intersectional approach is being covered by the various different types of healthcare professionals. And again, what we do see is a lack of diversity within our healthcare professional teams, not only across the university sector, but in society more generally. When you think about the number of Black and ethnic minority people that are nurses within the profession, within the NHS, and kind of in psychological services, it is a lot. So I think it's about the recruiting process we have and re-evaluating them and ensuring that we do prioritise the diversification of those spaces and the composition of those psychological groups. We do make that a priority in our hiring processes within universities, because that is a factor that universities can control, and they can make better use of positive action to ensure that.
Thanks, Jason. I think this is a really interesting point about the diversity in the workforce and the profession itself, actually. So it was one of the ones that we saw. It varies also by discipline. So psychiatry, clinical psychology and mental health nursing all got very different demographics within themselves, within the population. I think this is a really good challenge about how we work out what's going on in different areas and how we make that a place that everybody can feel welcome as well. I had a question here about long-term outcomes and what we know about those, and we've talked quite a lot of, does this have an effect often immediately. What we can see now is that the well-being of students and graduates is now being measured nationally, so we can track over time, but that's only just started. It's still experimental statistics. Do we know anything about the long-term outcomes for student mental health interventions? Is Bethan or Joanne, would you be able to start with those?
Yeah, I think it was already highlighted in the chat how many of the formal evaluations, such as through randomized controlled trials, tend to be in quite short term. They might be up to 6 months if you're lucky, you know, medium term. But long term, I don't know if it's we quite know that information. I guess some of it is down to the randomized control trial processes. So I'm involved in a trial at the minute, and we have up to 1.5 years follow-up, and that is really hard to do. they're so resource, time, finance intensive that I think it's very difficult to get that funding to sort of look at it in the long term, but also things about adherence and dropout and things like that as well. So I'm not quite sure in the long term what the long term effects of these are, or whether it's a thing you have to sort of top up every so often, you have to re-engage with the intervention every so often. That I'm afraid I don't know.
That's a great question. There's a couple of things there about the frequency with which you do things. So where it's a skill, do you need to keep building it over time, or if it's something that I saw one that said actually you're better off doing your meditation a couple of little minutes through the day rather than 20 minutes twice a week. So, and that might also be true with sitting and standing and physical activity as well, which we know improves our concentration and our mood as well. So there may be sort of frequency effects and things over time, but it does seem to me to be a gap, but also one that's probably harder to get research funding for. So those sort of long-term data sets, really good infrastructure investments for our understanding of what works in this area, presumably. Yeah, thank you. I've seen that Andre's posted in the chat some good youth self-harm research blogs as well. So I think somebody was asking specifically about self-harm and what we can do about that. I have another question here about from Andre again, actually, how many interventions are currently being offered by universities that have no evidence base? Do we know, Leigh?
I guess it depends what you mean by evidence base, because I'm sure, I mean, it's a really difficult one, because especially having done the pilot of the award through the pandemic period as well, what we have seen through the pandemic, it's been fantastic to see universities obviously really prioritising mental health and wellbeing of students through this period, and really investing actually in a lot of the mental health and wellbeing support. But with us being thrown into this unprecedented, yes I'll say it, situation as well that we've not been in, having to completely adapt the way they normally do things in terms of that support that they provide for students and the interventions they provide. We have seen a bit of a scattergun approach in terms of universities just like throwing things and trying to see what works. And in that case, how much has that stuff been evidence-based in terms of, you know, if they sat down and thought, what do we know what works, and have they kind of co-produced that with students and so on? We don't know. But does that mean that it was wrong to take that approach in that situation when it was needed? I think there's a balance, and there's always a tension between listening to what your community needs and being responsive to that and working that through, but making sure that you're, wherever possible, drawing on the expertise that you have. You know, a lot of universities now have clinical staff around. It's very easy to bring them in when you're thinking about these projects and designing that. So we do need a more joined up approach in that way, which the pandemic has been good as well to kind of start to make some of those more strong links between academic teams and wellbeing teams and things as well. But also to recognise whenever you do end up doing something like this, you know, evaluating that, and again is thinking about what makes good evaluation in that case. You know, universities aren't always set up for every single intervention that they do, same with student unions, to do some massive rigorously academic evaluation study on it. It might just be as simple as talking to the staff and students and making sure that you're getting the feedback there, which doesn't always happen. And I'd say that's probably the limit of what does happen with a lot of interventions at universities, is that they do kind of feedback surveys and things like that at the end of it. And that's a tension we've had to think about through the award as well, but around what do we think makes good evidence. And we might have had quite a high standard when we first went into that process, but then having to kind of reduce that every time we realised that universities don't aren't evaluating to that level, but are there other ways of them being able to demonstrate that it is effective? And so that's where a lot of that kind of qualitative evaluation comes in at that point as well. So yeah, I'd say there is a lot that isn't necessarily based or isn't evaluated, and some of it is a bit of a let's just do things and see what sticks, but that's not necessarily a bad approach, as long as you're doing it with students and responding to their needs as well, and making sure that you're thinking about how do we embed evaluation at that at some point once you've been doing that intervention for a while, I guess.
So I think this is a brilliant, it picks up quite a number of questions that we've had through the chat. Thank you very much, Leigh. So somebody was asking, Claire Battle was asking quite early on about how we get a multi-pronged approach that seems that sort of students, staff, social, academic, physical, emotional, how we pull them all together, and if there are good examples of it. And I suggest that probably you may well have some of those. My answer to that would be to go back to the principles and look at what you're already doing, what we already know. And the advantage of an evidence base that's brought together is that if somebody's already evaluated and it works, you just need to do it well in the right way. And therefore you don't need to do that research again. So I think that's quite important. I have a fantastic last penultimate question here, which is it possible for interventions to fail? So Professor Eccleston notes that lots of research is run by people who are passionate believers of the intervention. Is there a risk that interventions are doomed to succeed? And how concerned should we be about the rigour of these evaluations for mental health interventions for students? I'm going to go, I think, to Joanna on that one, unless Bethan wants to come in on it.
So that was one point we actually highlighted in the discussion of the review of reviews, that a lot of the reviews looked at the beneficial effects of the interventions. And yeah, so in terms of moving forward, it'll be useful for the body of evidence to highlight both the beneficial and if there are any adverse effects as well, so that we can operate on a first do no harm principle. I think that was a very important point that came from the discussion.
Brilliant. I think I've almost got my time. So I'm going to just ask each of the panel members one last question, which I think we'll also pick up in the workshop sessions after, which is, if you had £1 million, what would you spend it on? If you were just spending it on student mental health intervention or a policy change, what would that be? And I think I might go in order that I introduced you. So Leigh, do you want to go first? If you had £1 million, what would you spend it on?
I could quite selfishly say the charter here. So that's the way forward. But I do think there's something about having, and it's a bit of a cop-out, I guess, having a systems level approach to this, because I think there is a lot of good work that's going on, but it's about how are we being coordinated about it and bringing the right people in, and from, you know, the evidence that we've got, and bringing that into the practitioners and so on as well. And not just the charter, because that works at university level, but I think when we talk about systems level, bringing in NHS services as well, and you know, the Department for Education and those kind of national level policies around student finance and so on. I think there's definitely a scope to bring some more of that in. Probably going to cost more than £1 million, I've got to say. Another thing I'd just like to say, that some of the programmes that we see tend to be more expensive and don't tend to get as much investment as those ones that invest in co-production with staff and students, and collaborations across universities as well. So I'd definitely like to see more investment going into those, because they are expensive to do right, but we know that they end up with a lot of the time better mental health outcomes for the end users as well.
Thanks, Leigh. I know some of those cross-university collaborations and cross-system collaborations are being funded at the moment to test that evidence base. Bethan, what would you do with your £1 million?
Oh, I think there's too many things I could do. You could think about how university counselling services, a lot of them are underfunded, working on really tight budgets. Could we use that £1 million to quadruple the number of counsellors available, or provide sort of, or in other services at the uni that also help students' mental health but don't have the mental health label? So things like study support tutors, things like that, which also help students' mental health but maybe not in the same direct way. Could it be using counselling services to sort of have some sort of digital adjunct, either whether we use sort of automated things to make people's lives easier, to take admin tasks off their plate through using digital tech, or through some sort of digital intervention where there is a counsellor element to it. You know, digital interventions tend to be have better effects when there is some sort of human interaction or human support in there, but maybe from a trained counsellor. So yeah, I think looking at sort of what's already there and just boosting that, maybe.
Yeah, putting your money behind what's already happening, accelerating it, fantastic. And certainly we find from the time use studies that doing your life admin online is marginally less miserable than doing it in person. So there may be some digital systems effects that we can get some bonuses from. Jason, what would be your £1 million?
If I had £1 million, I would genuinely spend it on developing culturally appropriate mental health services, and kind of ensuring that all staff were trained in this area, and also employers, so that they knew the types of professionals that they had in and how they could upskill them and develop aspects of their kind of professional practice. That would be what I'd spend £1 million on. I need more than £1 million, similar to Leigh, because I'd do it across the sector, but that would be what I'd spend my £1 million on.
Certainly, I mean, yeah, getting you maybe more than $1 million would be brilliant. Joanne, you've got £1 million to spend. What would you put your money behind?
Well, I also agree with Leigh's point. I think joined up approach between universities and local NHS trusts. But I do think the area should focus on the wider determinants, given that there's a large body of evidence supporting the efficacy of such interventions in other contexts. So of course there are wider social determinant interventions which may be particularly important. So debt and financial management, quality and cost of student accommodation and housing, sense of belonging, etc. So that's where I put my money.
Brilliant, thank you so much. Really pleased someone mentioned the wider determinants. Feel free to put in the chat what it is your one thing you take away, your one message on your one action that you will do. And I'm going to ask Emily, who introduced us, to end with her what she would spend her £1 million on, and to close our session today. Thank you so much to all our fantastic panel and amazing questions from the audience.
Yeah, thank you. This was really very, very informative. And I guess my answer to the question is not exactly strictly speaking an intervention method, but something that I've been reading a lot about that I thought was really interesting was including green space in universities. And so the power of being outdoors and being in nature to actually help students deal with various stress factors. And there was actually a study published in 2018 that wasn't specific to students, but did see that greenness has a protective effect on depression, and so that being outside and being in green spaces is actually helpful for depression and anxiety. So I thought that could be an interesting aspect to also look at.
Certainly engagement from green space is a wonderful wellbeing equaliser. But I did do a presentation about it in the desert, and I realised that actually we should be talking about natural space and biodiversity. So blue space is some of the happiest places we can be as well. Thank you so much to our brilliant panel today. That was Leigh Spanner from Student Minds, Bethan Davies from MindTech, Jason Arday, who's a Professor of Sociology at Durham, and Dr. Joanna Worlsey from the University of Liverpool. Emily, I'm over to you.